the calm, scientific, and rational voice with a lot of professional advisories to countries, including India, on managing the pandemic. I leave it to the chair to more fully talk about Soumya's accomplishments. However, I must note that when we thought of inviting Soumya to deliver this year's lecture, we also had in mind that she is a daughter of Meena Swaminathan, who is a key founder of Mobile Creches, which is one of the principal supporters of this Anita Kaul lecture series. We are equally privileged to have with us Sujatha Rao as the chairperson of this year's lecture, not only because she is one of India's health policy experts, but also because she had known Anita well. Sujatha Rao is a former secretary in the Ministry of Health and Family Welfare in the Government of India and has remained a prominent advocate for quality of healthcare services, especially for the poor. In a long career span of over 36 years in the IS, Sujatha Rao worked in the health sector for nearly 2 decades and represented India in the boards of the Global Fund for HIV/AIDS, TB, and Malaria, the WHO, and UNAIDS, amongst other organizations. She also served as member of the Global Advisory Panel of the Bill and Melinda Gates Foundation and was a founding member of the Public Health Foundation of India. She has served on several global health advisories and is the author of a book which was a fascinating read to me, Do We Care? India's Health System, published by OUP, and she has been publishing several articles in the media and elsewhere. India's health policy today faces multiple challenges, and poor women and child health outcomes remain an overriding concern. NCDs, or non-communicable diseases, have emerged as a major disease burden. The adverse consequences of climate change have become and will become more visible in the coming years. Despite huge spendings on food subsidies, undernutrition remains a principal determinant and cause of poor health. There is mounting evidence that preventive and promotive health services offer quite sustainable and cost-effective solutions to many of our health challenges. Such interventions are best achieved by engaging with people and local communities. And therefore, the theme of this year's lecture of an inclusive health policy becomes relevant to ensure that the health system becomes more closely integrated with local communities and brought closer to the people. I'm sure that Soumya will bring fresh insights into the principal challenges that confront India's health system, including new emerging challenges, and give us the way forward towards an effective, inclusive, and people-centered health policy. Both Soumya and Sujatha, as you'll discover, are extremely engaging speakers, and you can look forward to a very intellectually invigorating and stimulating evening. I am confident that, as in previous years, this year's lecture will spark thinking and conversations on the real issues that confront India. I am personally happy that Deepa Dhanraj, who remained one of Anita's closest friends, is with us today and has flown in from Bangalore to share a few memories of Anita. Deepa is an award-winning and pioneering documentary filmmaker. And more than that, Deepa and Anita worked together to produce several short training films for teachers, women panchayati members, and other community representatives. This evening, of course, she joins us not as a documentary filmmaker, but as Anita's closest friend. And we'll begin the day with Deepa sharing a few glimpses of Anita as a person. Amongst us today, we're happy that Devika Singh, co-founder, and Rohit Bhasin, chairperson of Mobile Creches, is here. As noted, Mobile Creches is a key supporter of this lecture series, along with the Rainbow Foundation and the Center for Equity Studies. I thank these organizations for their support, especially Mobile Creches, who have provided all these years the background technical and logistic support. I would also like to make a note of Harsh Mandar, who germinated the idea of the lecture series, though he could not join us today. I especially welcome K.N. Srivastav, Director, India International Center, and take this opportunity to thank the ISC for the excellent arrangements they made for this event. On a personal note, I would also like to welcome Bobby Kaul and Kamlu Singh, the senior-most members of the Kriplani and Kaul families, for joining us at today's event. Rohan, our son, is here today, as well as my brother Ranjan, his wife Rekha, Anita's sister and Divya, Rohan's better half, have also joined us. Many of you would have known Anita and would remember her as a rather unconventional civil servant, quite unlike myself, who was more the typical Sarkari Babu. Though both of us shared the same values, we had very contrasting working styles, and Anita was more of a social activist rather than the typical civil servant, and was able to, even within the rather rigid civil servant space, find ways to reach much closer to the much more marginalized sections of society. Along with this lecture series, the Kaul and Kripalani families are also finding other small ways of supporting the causes and organizations that Anita stood for. As an example, we have been supporting underprivileged children of rainbow homes through the Anita Kaul scholarships to enable them to get through their graduation and move into rewarding careers. I now request Sujatha Rao to take charge of the event, and thank you all once again for joining us this evening. Thank you very much.
Thank you, Sanjay. So good evening to all of you. We are gathered here to remember and recall with respect and fondness Anita, who left us 8 years ago. Anita was a valued colleague and a wonderful, one-of-a-kind person, a hardworking bureaucrat with a very humane approach to all issues and problems she was called upon to handle during the course of her work. Full of fun. Every time I met her, she was just full of fun. She is remembered for a positive view of life and a completely smiling face. I mean, that today, the whole day, as I was telling Sanjay, Anita has been in my mind all along, thinking of her and her very vibrant personality. She had no business to leave us, really speaking. She is missed particularly nowadays when education is once again emerging as a single most important pillar of development. I mean, just as I was associated for health during my large part of my career, Anita was associated not only with education, but in education, again, adult literacy. And adult literacy is really the pillar of women's empowerment in our country. I mean, many of you would have been aware of how adult literacy class in a village in Nellore district of Andhra Pradesh really gave rise to the alcohol movement. And that is the kind of power that literacy missions had. And Anita, working under the famous Anil Bodia, piloted all that. And of course, later on, a lot of other things, reforms and so on that she brought about. So to tell us more about this very remarkable person, we have Deepa, a close friend and associate of many years. I would like to elaborate a little bit, though, as Sanjay has introduced you somewhat. But Deepa is no less. She's also really a remarkable person, a researcher, writer, and independent documentary filmmaker. Her documentaries and writings span a period of 40 years and engage with questions related to women's status, political participation, and resistance. In 2023, Deepa Dhanraj was given the Lifetime Achievement Award at the International Documentary and Short Film Festival of Kerala. That's really something. Co-founding the film collective Yugantar, Deepa initiated her work in the context of women's political movements around labor, domestic violence, and environmental conditions. Law as a site of inquiry has been an enduring theme for Deepa Dhanraj. Whether it is films that interrogate customary law and the strategies that tribal and Muslim women use to counter patriarchal verdicts, or formal law examining how a human rights legal practice began invoking the protection of the Constitution against the suppression of dissent, custodial violence, and state impunity. That's quite a bit. So really, Deepa, that's amazing. Most crucially, Dhanraj's focus was on how one could insist on governments taking responsibility for safeguarding the constitutional right to life and liberty of all its citizens. Now I understand why Anita was such a close friend of yours. The caste question and the myriad forms of discrimination that Dalits experience and the rise of Dalit assertion is another theme that Deepa Dhanraj explores in many films. She has a special interest in education, and she has worked extensively with government schools to create pedagogy suited for problems faced by first-generation learners who came from Dalit and Adivasi communities. She created these documentary films working closely with Anita. Her films have been screened and awarded at national and international film festivals, such as the Mumbai International Film Festival, International Documentary Film Festival Amsterdam IDFA, Berlin, Doc Leipzig, I'm sorry, I can't pronounce them, Oberhausen Film Festival, Festival International du Film Documentaire, Nyon, Switzerland, and Cinema the Real International Documentary Film Festival, Paris. She has served on juries at national and international film festivals. Deepa is a founding member of the Oral History Association of India. Deepa co-authored the book Rupture, Loss and Living, Minority Women Speak About Post-Conflict Life, with K. Lalita, published by Orient Black Swan, a volume that puts together the oral narratives of Muslim women survivors of sectarian violence that took place in Hyderabad, Mumbai, and Gujarat in the last 3 decades. The narratives presented foreground a critique of power and contemporary society rooted in these women's experiences of violence and survival. Deepa Dhanraj has also contributed papers on gender and development at national and international conferences. Friends, let's give her a big hand, and I welcome Deepa to please come and tell us more about yourself and Anita.
Good evening. Yeah. So I'm here really as Anita's friend. I just want to share how we first met and how this extraordinary friendship that started in trying to work together, how it grew and expanded, and how we, in a sense, influenced each other's thinking on many subjects, including education. So in 1994, I got a phone call out of the blue saying, from the Department of Women and Child Welfare, Karnataka, saying that please come and meet Madam Anita Kaul. You know how these secretaries call you, and very peremptory, and I was really shocked because I had never worked for government, and in fact, all my work up until that point had been very critical of many government programs, policies, and I was known for a film called Something Like a War, which really looked at the violence and corruption in India's family planning program, particularly directed towards poor women, tribal women, Dalit women. So I was really shocked that why am I getting a call from Sarkari office? And then I go and meet Anita, and she was unlike any IAS person I know, because she was very not at all, normally there's this big room, the desk, all of that. She came out to meet me, and we were pretty close in age. So, and then she said, she started by saying, I've been warned about you. So I said, warned about me? I said, what is this about? And she said, I've been warned about you, that you are a very, dangerous anti-government person. So, I mean, I started laughing, but then I didn't understand what she wanted from me. And then I said, well, do you want to watch the film? You watch the film and then we can talk. So I gave her a VHS tape in those days. I said, you can watch this film and we can talk later. And then she told me about this project, which was massive. It involved, for the first time, actually, something like 44,000 women had been elected into the Gram Panchayat, 94. And she was entrusted with creating training programs for these elected women representatives to actually, so that they could function in panchayats confidently. So in any case, I gave her the tape and I said, I went home and I said, I'm never going to hear from these people again. It was nice meeting her, but, nothing's going to happen. I know that. Next day, I get a phone call And she says, yeah, watch the film. Sorry, it's fine. Can you come in for a meeting? And that's how it began. So the task before us was immense because you're talking, first of all, as an independent documentary filmmaker, the idea that you're going to create material that's going to reach directly 44,000 women, it's in itself hard to, wrap your head around. And then we started this process, and that's something about Anita that I really admired, that once she got it into her head to do something, however radical, however revolutionary, and I would call her that, I said, you are taking on a very, a difficult sort of government structure, and you're trying to alter it from within, and it's not easy. You're going to face a lot of resistance. So her idea was that we would produce training materials, and ISRO got into the picture and said, there'll be a two-way process where you beam the video material to the women, and there's a two-way talk system so they can talk back to you. So normally when I looked at the ISRO material that they had done previously, it was very talk and chalk, meaning there was a person who would sit behind a podium and give a lecture, and then people from the other end would address the expert. And that was the first time where I told Anita, this is not going to work. I mean, we have to have women's voices. We have to have women physically present. I mean, women have to tell us, the ones who've been elected, they have to talk about their context, they have to talk about the issues they face. And then this hunt began over 22 districts, and we gathered a group of women who became and filmed focus group discussions that became the core of the training program. And while we were doing that, you see, I used to watch Anita all the time because these facilitated conversations, women were very honest and open about what they were facing. And each time I'd look over to her like, oh, we're recording this now. And she would never stop. There was no question of censoring. This material can't go in. Don't take the conversation down this road. So we continued, and at night, there would be these long conversations. And that's when I realized that, Anita would, though she was a very gentle person, and she was really made of steel. She could put a team together like nobody could, okay, and push that team to work together to achieve this. So there was one part, I just want one anecdote. So finally, when the rough cuts were ready, I'd call her in for the editing. I'd say, take a look at what women are saying, and she never once said, no, modify this is too strong. So before we telecasted, we met in her chamber, and the idea was that each section, there would be one secretary who would be the expert. So we would show this edited discussion of women, and there would be an expert. So there was one, you talked about the anti-Iraq movement. So there was this one discussion where a woman openly said, on one hand, you give us IRDP loans to buy goats, buffaloes, whatnot. And the other side, you seize all that money back by selling arak to our men. Why bother? I mean, what is this exchange, right? And that, arak reaches our villages before milk does. They're very angry, very impassioned. So, and I think the revenue secretary was sitting at the back, and he was steely faced. He said, he told Anita, this can't go. You can't have this. And, I was just sitting there, and I watched her argue with him, and saying, why not? That's what she's saying. It's true, isn't it? And she really stood her ground, okay? And when we telecast this episode, this was fantastic. When actually it went out, and this was in 800 centers in Karnataka. And in each center, there were, I think, about 100 women watching. And as this episode went out, and after this happened, and they bombarded him, and he was on this side, with questions about the availability of arak, the accessibility of arak, and how that leads to, they wanted a complete ban. And though, poor man, I mean, he was struggling. Really, there's not much he could defend the Sarkari policy. And then what happened, the miracle that happened is that women started using this two-way phone system to talk to each other. They completely ignored the panel. And I told Anita, that is when I think Anita and I just hugged each other. Like, something had worked, this extraordinary technology, figuring it out, all of that. But eventually, and then the conversation they had is that on International Women's Day, why don't we have demonstrations across the state demanding the stopping of the sale of arak, So these were, I mean, this is just one anecdote. I've gone over my 5 minutes, I think. No, I was supposed to do only 5 minutes. I'm sorry. Okay. No, just to say that when we started even the her support on things related to caste. Before we created this material, we also called all her trainers and showed her the material. And what Dalit women were saying was so, according to these trainers, so incendiary. They said, we can't take this on, right? We can't take this on in mixed caste groups. We cannot have discussions on this. So that's when we decided, okay, we'll shift this material into, we'll create little skits or plays so that there's some distance between the trainer and the material. And we had got together a team, which was basically they were, he was a Dalit poet who was a writer. The whole team was made up of Dalit community, creative artists. So, the language and of the plays was, in a sense, very provocative. It was really provocative. So at each stage, I would check with Anita, is this going to go down? Like, are you sure? Is this okay? For example, in one session, a woman said that if it was not for reservation, this is what a Dalit woman said, if it was not for reservation, I wouldn't be here. We would be treated, like those stray dogs on the street, even worse than that. Okay. So these kinds of lines, but in every instance, she just backed us. I mean, I had never experienced this kind of, I used to be more worried than she was as to, how this is, are you sure? Like, what is this going to make waves or not? And I think this continued. We did a lot of work together. I can go on, but I think it will be too long. I have a lot of stories about her. But one thing is that her ability to lead, to organize, to keep people together as a team, disparate people who normally would never be working in the same group, this was extraordinary, And it's just her vision, I think, I used to always say, it's very hard to be an activist as a bureaucrat, because you're working in such entrenched feudal hierarchical structures and you're trying to change something. And how is that working for you? These were the conversations. And she was such an idealist. She would keep saying, no, but it will happen. Eventually something will change. Something will change, And I was talking to Rohan outside and I said, I do think that her experiments with teachers, school teachers, empowering primary school teachers, I think there's a group of, say, I would say at least 50 people maybe, who have been altered by this exposure to her, working in this way, and that has lasted, And as for myself, I mean, even though we stopped working together, but for me, Anita was always my touchstone. Whenever I started a new film or I got stuck in an edit, I would call her my wailing wall, because I'd call her and say, now, Anita, look, this is XXX. And she would go, enough now, get on with it. Just finish it. So, yeah, so I think she was, I miss her. I miss her a lot. She really left too soon. And yeah, it's just, there is a big, there is still a void, I think, for people who knew her, who loved her. I think that how special she was is really something we can't forget. Yeah. Thank you.
Thank you, Deepa. That was very touching. And now that you mention it, I recall her telling me about this Panchayat Raj experiment that she was doing those days. And I remember I was in the Ministry of Health and I went and we were trying to see how we can bring in health also. And it was a very, very powerful experiment. And, I mean, it also kind of shows, and many bureaucrats are here, that kind of space. I mean, it's an ironclad bureaucracy, but it still gave space for individuals to be creative, provided it's inside you. And Anita had that creativity that she brought to her work. And she was able to see the power of communication and how to bring in intersectionalities and how to bring people together. That was a rare quality, and not many share that, but Anita was special. So now we have another remarkable woman to talk to you all today, and that is Soumya. I mean, you might wonder, what does health have to do with Anita? Lots, because education is a determinant of good health. And so, though she never really worked in the health sector per se, but I would say that if she was watching us from somewhere, she'd be happy that we are trying to talk about health, because she was as concerned about what was happening in the social sector itself. I mean, 25 years of her 36 years she spent on social development. And anyone working with women and education, Panchayat Raj, cannot keep health out for too long. It's all one big round thing. I mean, you just have to intersect with it. So we have Soumya, and her introduction I have I'm very honored to give. Soumya Swaminathan, a renowned pediatrician and global expert in TB and HIV research, recently served as WHO's chief scientist and previously as Deputy Director General for Programs at the ICMR. Returning to India, she assumed the role of chairperson at the MS Swaminathan Research Foundation in February 2023. With over 40 years of experience in clinical care and research, Dr. Swaminathan has dedicated her career to translating research into impactful health programs. She held prominent positions such as Secretary to the Government of India for Health Research and Director General of the ICMR. Her efforts focused on integrating science into health policy making, enhancing research capabilities in Indian medical institutions, and fostering global partnerships in health sciences. Dr. Swaminathan received her academic training in India, the UK, and the US, and has authored over 480 peer-reviewed publications and book chapters. She is a fellow of the US National Academy of Medicine, the Academy of Medical Sciences UK, and all major science academies in India. She holds honorary doctorates from prestigious institutions including Karolinska Institute, EPFL Lausanne, and the London School of Tropical Medicine and Hygiene. She serves on numerous national global advisory boards and holds adjunct professorships at Karolinska University, Sweden, and Tufts University. I think the first question we should ask is, how does she manage a diary? I really don't know. Currently, Dr. Swaminathan serves on the boards of Alliance Bioversity, Coalition for Epidemic Preparedness Innovations, CEPI, and then FIND, Population Foundation of India, among others. She's a member of the Governing Council of Tamil Nadu Climate Change Mission and chairs the Scientific Advisory Board of the ICMR. During her tenure as WHO's first chief scientist, Dr. Swaminathan established a science division focusing on research, quality assurance of norms and standards, and digital health. She played a pivotal role in coordinating global scientific efforts and was instrumental in setting up COVAX to ensure equitable vaccine distribution to low and middle-income countries during the COVID-19 pandemic. She is also the principal advisor. Recently, she was appointed as the principal advisor to the Ministry of Health and Family Welfare, Government of India. So I don't think we can get a better person to talk about the paths for inclusive and people-centered development and health policy development in India. Soumya, all yours, please.
Thank you very much. Good evening, ladies and gentlemen. Firstly, let me thank Sanjay and the family of Anita Kaul for having thought of me and inviting me to give this lecture in her memory. In fact, I could have kept listening to Deepa all evening. I think there was no need for another lecture. It was so wonderful to hear about Anita and the way she worked. And I'm really sorry that I did not know her, get a chance, to interact with her or meet her. And obviously she left us all very early, but clearly has left, huge legacy. And I think it's wonderful that you have this annual event to honor her. So it's a real honor for me to be here today. And I'm sorry that, this introduction was all a bit, too much. But thank you so much for that very generous introduction, Sujatha. And now somebody has to help me to get this slideshow on. So one thing that I did notice about Anita also was, there were some pictures on the screen and some slides that were going on. And one of the quotes or things she said was, whenever I'm in doubt, I go to the people, something like that. I'm just paraphrasing. So that's something I can, it resonates with me also a lot, because even when I was here in government service and, had worked for a long time in government, I was in ICMR for more than 30 years and then ended up as Secretary Health Research and then went to WHO in Geneva, where you feel even more isolated from what is actually happening on the ground. You're at such a high policy level over there. But even here, every few weeks, I felt the need to really go into the field. And I would, call someone and say, okay, I'm coming to visit either an NGO or somebody doing some work. Could be one of the ICMR institutes as well, but the more remote the location, the better. And that always re-energized me, because I felt, okay, connected with what is actually happening on the ground. And we're not doing something here in the corridors in Delhi, which has nothing to do with reality and what people actually need. So I think that's even today, I think that's very critical. And you can see on this slide is we work in Koraput district of Odisha, which is one of the tribal districts, and in fact used to be part of the very notorious hunger hotspot of the KBK, Kalahandi, Koraput, and Bolangir. Luckily, it's not that bad anymore, but still there's a lot of issues of health and nutrition. So on my last visit, I went to lots of Anganwadis and and health centers and villages where we sat down. And of course, the language is a barrier, but still sitting down and trying to understand what the people need, what they experience in their day-to-day lives, it sort of humbles you, it really humbles you, and you feel that, gosh, you come from quite a different and much more privileged life when people are really struggling for very basic things, and they accept it also. I think that's the thing about these people who live in poverty is, you don't see anger and resentment. They carry on with their lives, and they're so generous with with themselves. So in the topic really, it's about the inclusive and people-centered health system. The other thing I should say is that, of course, I see so many friends and colleagues, ex-colleagues in the audience, and many of you are very senior people who worked in health policy at very senior levels. So again, it's a bit, trying to preach to the choir, but hopefully we can have a conversation about this. I don't pretend that I'm going to give you all the answers here. Now, the one thing that I do want to say right at the beginning is that when we talk about health, the first thing that comes to mind is healthcare. It's hospitals, it's clinics, it's doctors, it's nurses. But if you actually look at what determines health, the social and economic and environmental determinants of health, Sujatha was talking about education, for example, being one of the determinants of health. Mother's education is the single most important factor for a child's nutrition, a child being well nourished or not. So healthcare is one of the determinants of health, but you can see that there are many other determinants of health. And this, of course, includes rights and economic stability and the environment and the social and community context. Then we have, of course, universal health coverage, which is what we all aim for. And the definition very simply is that all people have access to a full range of quality health services without financial hardship and when and where they need them. So that really is what is the ideal when we talk about universal health coverage, but it's very often been either parsed up or, elements of it get addressed. Now, this is, everyone here knows what our demographics is, but it's just to say that, we have growing urban population. We, at the moment, are a young country, but that will change over the next few decades. We, of course, have a very large population and a population density. And the urban areas, which are attracting more and more people from the rural areas, currently 40%, but again, expected to grow. And the slum population is a very large proportion, almost half of urban populations. Now, the mandates for health and healthcare have evolved starting with our constitution, and we do have in our constitution the right to life and the right to health. And then, of course, we also have determined by the constitution the list of the topics which are under the union list, which are controlled entirely by the central government, the concurrent list, where you have things like population control, family planning, drugs, medical education, medical profession. And then we have the state list, which deals with public health and sanitation. So, of course, the segmentation here is a source of strength, but can also be, result in passing the buck one to the other. Now, our health policy journey has been quite long, starting from well before independence. And I don't want to read everything that's on this slide, but it's not only about health policy, but also some of the related areas like sanitation, like salt iodization, which all started in the 60s, the National TB program, the iodization program. And then we've had so many committees, actually periodically, starting with the Joseph Bohr Committee in 1946, but then having so many committees after that, each one looking at where we've come. And then we've had the major changes. Of course, Alma Ata Declaration in 1978. India also signed up to that, which was basically to achieve universal health coverage through primary health care. Our first national health policy was in 1983. The next one was in 2002, and then the latest was in 2017. And the Ayushman Bharat program was launched in 2018. So I want to talk a little bit about the three more recent landmark events, which is the National Health Mission, which started in 2005. And you remember at that time, we were still in the MDG era. So the focus was on maternal and child health and nutrition and a certain set of communicable diseases, mainly HIV, TB, malaria. Of course, free drugs and diagnostics was brought in, urban health initiatives, and community participation was a large part of this. It did set very much the foundation for the health system that we have today in terms of the most recognized one, of course, is the introduction of the ASHAs, and who were recognized by the WHO last year. They received a public health award from the WHO. We have about 1 million of them. Financing with a center-state ratio of 60:40 and some conditional-based funding, and setting up, the foundational systems like supply chains, infrastructure, data systems, and so on. The National Health Policy of 2017 then followed, which did set some targets. And some of the targets that were set at that time, for example, was that, and this has been done repeatedly, the National Health Mission of 2005 also said the government health expenditure must go up from what it was below 1% at that time to 2.5%, even at, I think by 2010 was the goal at that time. Then the National Health Policy said, let's go to 2.5% of GDP by 2025. Currently, we're still around 1.5% or so. The government spending on health was to go up to over 8% of the budget by 2020. We're not there yet. We were supposed to reduce the households with catastrophic expenditure by 25%, and we have reduced it, but really not good enough. We still have 55 million people falling below the poverty line due to catastrophic health expenditures. We've done well in other areas, total fertility rate, under 5 mortality rate, neonatal mortality rate. We've done very well with HIV, AIDS, and Sujatha was very much part of that program. And there are reasons why I think it was a success. But stunting, for example, and childhood undernutrition, we still have very unacceptably high rates. So then came Ayushman Bharat after the National Health Policy in 2018, and it's had two major pillars. The first one has been around strengthening primary health care, essentially by setting up these health and wellness centers. So what were called the sub-centers earlier under the primary healthcare centers were upgraded, and then you now have a community health officer there, CHO. She now has a team of a multipurpose worker, 2 ANMs, the auxiliary nurse midwives, and about 5 ASHAs. And she's supposed to be trained and deliver 12 packages. And we can talk a little bit more about, this package-based approach to healthcare and, whether it's a good thing or not. But the other major element of Ayushman Bharat, of course, is the PM Jan Arogya Yojana, which is a government health-funded health insurance scheme run by the National Health Authority. It covers about 54 crore Indians based on the most deprived, and gives a coverage of 5 lakhs per annum to these families. And very recently, all people over the age of 70, regardless of their economic status, have also been included. So you have primary care delivered essentially by government system through the primary health centers and the sub-centers or the health and wellness centers. And you have secondary and tertiary care that has insurance coverage, which covers about 1,900 procedures. So it covers mainly in-hospital care and surgeries, but provided by both public and private hospitals. Now, one of the things that's happened in the last few decades, of course, is that private sector has started dominating the provision of health services in India. And this has been growing over the past few decades. There's a huge valuation to this market. It's also a large employer. But you can see that on the top graph, you can see that the public sector provisioning of care has been going down. Private sector has been going up. And at the bottom, you can see outpatient and inpatient, both dominated by the private sector. But private sector, of course, is not a uniform or a homogeneous thing. It ranges from, one-room clinics to huge multi-speciality corporate chains that offer medical tourism. And in rural areas, there is less private sector, but even there, it is predominant. And again, there could be many people there who are not even qualified doctors. We know that there are a lot of not just traditional health providers, but also a lot of quacks where there is no access to government services or good private services. These people, of course, exploit the local population. We've talked about the low level of resources. So we haven't, if you really look on the top graph, it shows that India is spending about 3.8% of GDP in healthcare. Again, 2/3 of that is coming from private and only 1/3 is coming from government. And compared to USA on the extreme left, which is about 17% of GDP goes to health. Of course, that's very different and perhaps one can say a very wasteful system. And then you have many other countries in the middle, like Brazil, China, South Africa, and so on. And if you look at the bottom, it's the total health expenditure per capita. In 2022 for India was $74 per head. But again, if you compare other BRICS countries, you can see that, they've all started at the same or slightly higher, but they've been going up over the years, whereas India stayed more or less between 3 to 4% of GDP now over many decades. So we really haven't gone up, and in absolute terms, in fact, might have come down. On the right-hand side, we see the split between primary, secondary, and tertiary care. And the light blue is 2019 and the dark blue is 2022 figures. So you can see that there's actually been a reduction in health financing to primary health care with an increase in tertiary. We're building more tertiary hospitals, AIIMS, etc., medical colleges. Of course, we have made progress. It's not that we haven't. So over the years, we've reduced the disability, the morbidity, mortality. We've eliminated a number of infectious diseases. In fact, no one believed India would eliminate polio. we did. Maternal and neonatal tetanus. I remember when I was training at the All India Institute, this was in the early 80s, we used to get a child, a newborn with neonatal tetanus almost on a daily admission basis, and these kids would come from UP, Bihar, very far away, and you could see from a distance and diagnose. It was terrible because of application of cow dung to the umbilical cord. We've eliminated it because of the maternal tetanus immunization program. Similarly, Kala Azar, leprosy, filariasis, measles, rubella, these are all getting close to elimination, but we're not there yet. We do have a lot of new challenges, actually, which got recognized very recently. And in 2016, when I was at the ICMR, we released for the first time a state-level disease burden estimations. These were pulled together from all data that was out there. And basically what it showed is that between 1990 and 2016, we had a complete epidemiological shift where communicable diseases were no longer the predominant cause of death. It had shifted to non-communicable diseases like diabetes, high blood pressure, heart disease, and also injuries. And the top causes of death now were, cardiovascular disease, respiratory diseases continue to be in the top, followed by cancer and so on. Of course, COVID during 2020, 21, 22, COVID also figured in the top 5, 6 causes of death. It's no longer over there. And what had not been, many states had not recognized this because from the MDG era, we were still focusing on maternal child health and infectious diseases. States like Kerala, Tamil Nadu, Goa, the southern states had shifted even in the 90s, actually. They had made the transition to non-communicable diseases, but that was not there in the policy and the planning. This study, which is called the INDIAB study, that was funded by the ICMR, it ran over a long time. 15 years it took to complete the study over the whole of India, basically to do prevalence of diabetes. They looked at also hypertension, lipids, and obesity, and so on, and found that 11% of adults in India actually have diabetes, and another 15% have pre-diabetes, which means they're all going to become diabetic within a few years, with a much higher burden in the south and a higher burden in urban areas. But the fastest growth was actually in rural areas, and there was no difference between rich and poor and all that. Diabetes is just rampant. 100 million people currently, with another 136 million with pre-diabetes. And the thing is that most of these people are undiagnosed. They don't know they have diabetes, or if they know, they're not getting good care for it. It results really in a very severe loss in terms of quality of life. I think those of you who have experience of diabetes would know, because the kind of complications that you get, huge increase in out-of-pocket expenditure and catastrophic expenditures, and a big, reason for going into debt. The other thing, of course, is that we're aging. So today we're on the pyramid on the left side, where we have a very large young population. But in 2100, we're going to be, people who are born today are then going to be 75 years. So the bulge is going to be in people between the ages of 65 and 75. And, India produces 20 geriatricians per year. So we're going to have this 300 million 65 plus people by 2050. And not only are we going to have more older people, but they're not necessarily going to be healthy. So the problem is 75% of the elderly suffer from one or the other chronic disease, or have some form of disability, require assistive devices, and also mental health issues are more, and neurodegenerative diseases. So the lack of preparation, lack of expertise for simple things like physiotherapy, rehabilitation, assistive devices. I want to say something about Thailand, because several times Thailand comes to my mind as a real exemplar in many of these things, including in the way they look after the elderly and the disabled. So I've visited some primary health centers, and next door they'll have a room where they welcome the older people from the community to come and spend the day. They have activities there. There's music, singing, dancing, other kinds of, craft work happening. You can do cooking. They spend time there. There's company for them. And similarly, in the village I visited, I found that there was a community center there which cared for people who had disabilities. So like say people with stroke who could not be left alone at home because the younger people in the household were working, they would stay in this center for the day, and there would be 1 or 2 staff to look after them. And they were very simple physiotherapy equipment, like locally made things, not expensive gadgets, but things that could be made out of wood, local materials. And these people, again, the disabled would be, and the elderly would be cared for. That's really, what we're going to need, and we already need. There have also been many estimations that apart from the fact that people die because of lack of access to healthcare, that's estimated at about 1.5 million people in 2016. Actually, many more died because of poor quality healthcare being delivered. So it's not just enough to have a health center or a facility. The quality of services needs to be good. And if we look at things like anemia on the left-hand side, or blood sugar in the middle, or stunting in children on the right-hand side graph, you can see that there's wide variations between states, in this case, districts. So one policy, one approach clearly is not going to work for India because there are so many regional differences. And gender is another important element here. On the right-hand side, you can see in red the percentage of women having a mobile phone, and in blue is the men. This is data from 2019 to 21. So this may have obviously improved, but also you can see the variations between states, with Goa and Sikkim, Kerala at the bottom, and Madhya Pradesh, Chhattisgarh, and Uttar Pradesh on top. So state-wise differences, gender-wise differences, and of course, other things like socioeconomic status and so on. And therefore, household decision-making clearly is also impacted by the lack of gender empowerment. Now, I just want to go on to taking 2 examples that underscore many of the issues or complications that have arisen in the health system, and then illustrate some possible solutions. So I want to talk about tuberculosis. This is something I've spent most of my life working on, and I'm very happy that I now have the opportunity again to work with the Ministry of Health as an advisor on tuberculosis. As you know, we had committed to bringing down TB to elimination levels by 2025, ahead of the UN SDG targets, and that's in 2025. We're not going to do that because if you can see, we were supposed to come to incidence of 44 per 100,000 by 25. We're currently around 195. The mortality target was at 3 per 100,000. We're currently at about 23. And so these are the 3 goals set by the WHO NTB strategy. One was to reduce incidence rate by 80%, the mortality rate by 90% from a 2015 baseline, and catastrophic expenditure, because we talked about people going into poverty because of health expenditures. TB is one of the really common conditions in India, which actually push people into poverty, which is very sad because the government has a program that provides free diagnosis and free treatment, and yet people have to shop around for diagnosis for a long time before they actually come into the government system. So the catastrophic expenditures, unfortunately, we don't have good studies documenting that in India. So it's very difficult to say how many people did fall into that trap due to TB. But in terms of funding for TB also, in the bottom right-hand corner, you see that the funding actually has been coming down from 2019 onwards. So the pandemic years, it was very low, and TB got really bad during the pandemic years, like many diseases, because everyone was focused on COVID, and then, it's gradually making a recovery, and hopefully this is going to keep going up, the funding. But the other thing is that what are the risk factors for TB? Why does India have such a big burden? And the most important risk factor here is undernutrition. And you can clearly see that where you have more TB is those places where you also have a lot of poverty and undernutrition. So our tribal districts, our aspirational districts, and our urban slums. The other big risk factor is alcohol use disorders, was talked about earlier today. And this is really, really a growing, I think, going to cause a huge burden of disease and illness. I can see in Tamil Nadu, for example, that that alcohol use disorders not only is leading to more TB, but is leading to a lot of premature mortality among men due to liver failure, due to heart attacks and things like that. And yes, I think, my mother also used to say when she used to talk to women's groups, because they used to love the freebies that the government of the day was giving them. And she used to say, would you rather have your husband alive or do you want these freebies? Because basically it's a choice between, making money. The government makes a lot of taxes, obviously, out of alcohol sales, and then is then able to deliver other services. So it's a difficult one to handle, but it is a very big risk factor in many of our states. Now, recently, there have been some good developments on the TB side. One is that instead of these poor people who have multi-drug resistant TB, this is the number of drugs that somebody has to take in a day. Luckily, now we have a new regimen where they'll only have to take these 5 drugs. The government has announced that it will be rolled out very soon. It's also more effective, and hopefully many less people will die if they get access to these drugs. Nutrition support. We know that malnutrition is not only an important risk factor for TB, it also worsens outcomes. So if you're malnourished and you get TB, you're much more likely to not get cured. So the government has now doubled the direct benefit transfer from 500 to 1,000 rupees per month for every TB patient for the duration of treatment. So they can hopefully spend that on buying. And there have been studies, impact assessments done to see what do people spend this money on. The majority of them actually spend it on food. The government also announced these nutritional supplementation, energy-dense nutritional supplements for all patients who are severely undernourished. And there was a very important study that was done in Jharkhand a few years ago that was published in the Lancet last year that showed that this was done, of course, in impoverished tribal population, but if you gave the family a monthly basket of rice and dal and oil and some protein, you could actually reduce by 50% the number of TB cases in the family. Now, you know that we don't have a good vaccine for TB. We have BCG, which is very old and not really that effective. So nutrition actually is the only vaccine we have for TB today. And if you make sure that people are not undernourished, our TB burden will come down immediately by over 50%. The other thing, of course, is that people who are affected, and Sujatha knows this very well from the work in HIV/AIDS, and many of you have been involved in, that when the key populations, when the affected people start playing a role and they have a voice and they have agency, then, no one thought India, everyone had projected horrible things for India as far as HIV/AIDS was concerned, but it was turned around. And a large part of that is because the sex workers and, the people who were really getting impacted with HIV and local community-based organizations and civil society organizations were empowered, were funded by government, and really played a major role. In the case of TB, that hasn't really happened to the same extent. I was in Kerala and Wayanad last week, and I visited this house of a tribal patient with TB who had just died. I mean, this 25-year-old woman had died, leaving behind 2 children to be looked after now by her mother. The husband had abandoned the children. And I was trying to find out, could this woman's life have been saved? What could have been done through these? So these were all the district officials with me, the TB officials, to say, could we follow her journey? She lived for 2 months after she was diagnosed with TB and then still ended up dying, So where did the health system actually fail her? So we know that these people are especially at high risk, especially when you have a tribal, a woman, poor, remote, all of those things, intersectionalities then make them very, very vulnerable. So the state will have to make special programs, for these communities if we really want to control TB. And again, the population there is really not involved in a big way at all. Neither can they demand services. We now have excellent diagnostics. Earlier, we were just doing sputum smear microscopy, which was not sensitive at all. But today, we can take a handheld X-ray, which just looks the size of a camera, really, a large camera. It has an artificial intelligence algorithm built into it. You can take it on a motorcycle, put it in a backpack, or if you've got a mobile van, take it, screen people in the village right there and then. The AI algorithm is going to tell you if the X-ray is normal or not, and then you can proceed with the rest of the investigations. So that's, you can see those people on the left-hand side doing that. Similarly, we have what are called NAT is the technical term for it. These are, rapid diagnostic tests, molecular tests. Like for COVID, we scaled up COVID testing. We were doing, millions of COVID tests a day in India. We did it in very rapid time, but for TB, we haven't got there. We still have only 20% of people who come with symptoms are being offered this test, which is really the gold standard, which we should be offering everybody. So our goal now is, and I'm trying to do my best to make sure that we get from the 20% we are at now to 100%. Anyone who comes in with symptoms must have access to the best test. Otherwise, you're just going to keep missing cases. The other complication we've now discovered for TB is that a lot of people have subclinical or asymptomatic TB. This is something globally now being recognized as a phenomenon, and we don't have a good solution to this. So if you don't have symptoms, you don't have a cough, you don't have fever, you're not going to go get yourself tested. But when you do a prevalence survey in the community, you find a lot of people who do infectious. How are we going to find those people? Probably through these X-rays. And studies in B, example, have shown that if you go into village and you take an X-ray on everybody, you'll find everyone who has TB, you'll treat them. And if they did that for 3 years in a row, once a year, they really brought down the burden of TB in those villages. Of course, it is resource intensive. But early diagnosis is really the key to look at these malnourished people. So once you're in this kind of a situation, you get a lot of complications, and it's then very difficult to bring you out of it. So the thing is, early diagnosis can also reduce our the deaths. And most of the TB deaths occur in the first 2 months, as I said, because of delayed diagnosis. So the other thing we need is better health, medical treatment in our primary health centers. I've been going to various primary health centers and, talking to doctors. And I must say that our medical education does not give doctors really the grounding to sit in a primary health center or a CHC and take care of the problems of people over there. So the other thing is we don't have beds because TB is considered an infectious disease. So many hospitals say, no, we can't admit a TB patient here. You've got to then travel hundreds of kilometers, which these sick people obviously cannot do. One thing that one has started now doing is what we call death audits, just like was done for maternal mortality. There was a huge priority for India. Of course, maternal deaths we brought down significantly by, doing an audit for every pregnant woman or woman who delivered, who died, saying what happened, why did it happen, what went wrong, what can be fixed. That's the kind of thing we need now. For every TB death, I think collectors must find out and really dig into the details, not just, okay, this patient came in very sick and died, but then go back and say what actually happened right from the beginning. So if we start doing that and taking corrective action, then we can start reducing mortality. And personally, for me, I think to have 1,000 people a day dying of TB today in India is really something that none of us should accept. And if we have to do anything in the next year or two, it must be to reduce that number to as close to zero as possible. We can worry about bringing down the incidence and all that later. That will happen. It will take time because we are such a high burden country. We're not going to get rid of TB tomorrow, but we can prevent people from dying of this preventable and treatable disease. Now, the next thing I want to talk about is very different. It's a non-infectious problem, but it's something all of us here are experiencing just now. And air pollution and climate change. Now, air pollution is the third major risk factor for death in India after poor diet, which is number 1, and high blood pressure. Kills about 7 million people annually. Out of that, 1 in every 8 deaths is in India. And you've seen these models which suggest that it's taking about 5 years off the life of people who live in North India. Globally, air pollution takes about 2 years off the life of people. So 99% of people in the world live in places where the air quality is very poor. These graphics are showing you carbon monoxide at different times, in pre-monsoon, things are looking yellow, and then after monsoon, it gets a little bit better. And then in the winter, you can see again, it's all building up. I mean, we've all experienced this. And of course, it's one of those things which is not limited by any kind of boundaries, either national boundaries or state or district boundaries. There's an air shed which connects everyone. So this is why I'm part of a global commission, which is called Our Common Air. Air is something common to all of us. And so we have to act together on it. Now, what do we need to do? We should value clean air as an asset, not just look at it as, yes, it's killing people, it's terrible for health. But clean air is an asset, and it's an economic asset, because if you have polluted air, then, investments are going to go away. People are not going to come and want to stay in a place where the air is so polluted. So we need to address PM 2.5, which is the most dangerous particles, but there are other things like carbon monoxide, sulfur dioxide, nitrogen oxides, ozone, etc., black carbon. All of these are called short-lived climate pollutants, methane. So there are many pollutants, not just the black carbon or the PM 2.5. So air shed management is really the joint responsibility across political boundaries, including international ones. And so what we're trying to do as Our Common Air is to really raise the issue globally, to get countries to agree to monitor and report, because currently we don't have any global system of monitoring or reporting on air quality data like we do for so many other things, for malaria or TB. Every year there's a report. We know how many cases there were. We know how many deaths. We know how much financing went into that. For air pollution, there's nothing. So we need that kind of global accountability, just like we have climate, we have nationally determined contributions. We need to say, okay, this is how much we're going to reduce it by, and this is how we will do it. And of course, we need technology, so we need global collaboration. There are solutions, and there are many examples of cities that have cleaned up their air, including Beijing, including Mexico City, including London, for example, the ultra low zone emission. But again, it's one of those where the action is not in any one department or ministry. It's not the health ministry or the environment ministry or transport or agriculture or industry. They all have to contribute, because the sources of air pollution are coming from all of these sources. So you need all of government approach to do this. You need commitments, and you need a plan based on the science, based on the analysis of what these pollutants are and where they're coming from. And of course, one of the simplest things, or the most probably a win-win, is public transport. So investing in public transport, in buses. Of course, everybody's building a metro now, but more than metro, it's buses, particularly if they are clean buses, like electric buses, and disincentivizing cars, whereas we are doing just the opposite. We're incentivizing cars, we're encouraging people to buy more cars, and we're disincentivizing, or we're not building our public transport to the point we need. And I was at Labasna last year and heard Shashi Verma, who's the Chief Technology Officer for Transport for London, talk about public transport in London and how it's in central London. If you want to buy an apartment or a house, you have to commit to public transport. There is no parking for you, either inside or outside your house. And so if you want to live in central London, you have to use public transport. And that's resulted in lower obesity rates in central London. The moment you go out of London, you see more obesity. So people who use public transport are healthier, fitter. You can also then have cycle lanes, pedestrians lanes, and so on. So there's a lot to say for that. And I think if there's one thing we should do, is that. The second thing I would say for pollution we need to do, which is absolutely urgent, is indoor air pollution, which again disproportionately impacts women who cook using biomass. Again, when I've been traveling through rural areas, impoverished rural areas, while everyone has an LPG connection in their house, most of the time the cooking is being done by using wood or biomass. And this is because of the affordability of LPG. When a woman has to cook for a large family, she can't afford to do it. So they do stacking, energy stacking. And so, again, the government had a wonderful program, what was it called? The free LPG. Yes, Ujjwala, yes. So if the Ujjwala scheme could continue with some kind of, subsidies for these, just the most, women who cannot afford, just those families alone, while others, we can afford to pay a little bit more. We don't need a subsidy on our LPG. But unless we do that for these women, they're going to continue to Firstly, it increases drudgery. They have to go out every day and collect firewood or dung. And secondly, it's very bad for the health because they and their children are breathing in that air. And thirdly, it's adding to the outdoor air pollution. In India, in every part of India, indoor air pollution, or because of this burning of biomass, contributes more than 40% to outdoor air pollution. So by that one intervention, you can cut outdoor air pollution, and it will be good for women's health, gender, and as well as children. So I think it's a big win-win, and we have to convince the government that that's a worthwhile investment. Now, of course, climate change, now we hear a lot about climate change and how it's going to impact our health. Yes, it's going to make things worse. Pre-existing things are going to get worse. We may not have very new things coming, but heat will get more prolonged, it will get higher. Vector-borne diseases, dengue is going to be there throughout the year, and, malaria will spread to places where there was no malaria before. Things like that. Of course, it also impacts the health system as well. And if you're already, again, vulnerable, then it's going to impact you more. So the gender impacts of climate change is what worries me the most, because women are now have a huge burden on them of doing agricultural work, household work, childcare, providing for food. And if there's water scarcity, for example, they have to walk that much longer to collect water, spend that much more time. Natural disasters, UNDP has shown that women have a much higher risk of dying in natural disasters than men do. In conflict and displacement, of course, again, forced migration, either the men migrate and the women are left behind in the rural areas, or the women also migrate and have a very poor quality of life in our peri-urban areas. So India is one of the most vulnerable countries to climate change. Almost every district is affected, though variably some are more prone to drought, some are more prone to floods or cyclones. But the fact is that 80% of our population does face some sort of climate risk. And you can see on the right-hand side is the increasing projection of precipitation. So that's going to increase rain, and below we can see the impact of extreme heat and humidity leading to lost working hours. Now, this was a report that we did earlier this year and submitted it to the Ministry of Women and Child Development, where we were asked by them actually to do a scoping study looking at women across agroecological zones, because normally we look at state or district boundaries. We never look at India in terms of agroecological zones. So we tried to do that. It's hard to find data in that way. But what we basically found is, again, not very surprising, women definitely disproportionately impacted, especially pregnant women and young children. What was most shocking was the gender-based violence or the domestic violence that we saw increase with chronic exposure to, for example, drought. So we looked at NFHS data over 10 years, the last two NFHS, and we superimposed it on districts which had more drought in the last 10 years and those which did not. It was a clear increase of 25% in domestic violence in those districts which had recurrent droughts in the last 10 years. So women, again, bearing the brunt of domestic violence. Children's education is impacted. But again, the data is still sketchy. And so we've made a number of recommendations in that report. I'm not going to go through them. The report is on our website. But we need better governance of climate and its impacts. So we need leadership at the highest level. Again, it's a multi-sectoral, whole of government type of approach. The National Action Plan on Climate Change and the National Action Plan on Climate and Health has to promote synergies between climate change adaptation and health system strengthening. Excuse me. The other big change I think that we need is really more shifting of responsibility to the local level, whether it's a panchayat or whether it's urban local bodies. And we know now that, except perhaps with the exception of Kerala, that local bodies are not empowered and neither do they have the financing. But to deal with climate change, it has to be done at the local level. One cannot have climate change policies really being done for the whole of India at the national level. You could have, of course, at the very high level. But ultimately, it is the panchayat, it is the local urban body that has to deal with these local issues. And so I hope that the 16th Finance Commission will consider much more devolution of powers and financing down to panchayats and local urban bodies. Our cities, of course, are becoming like urban heat island effects, which is again affecting the poor more because their housing doesn't have the facilities for cooling. But we've also got to look at these gendered aspects like, migrants, when you have emergency shelters to make sure that they are gender sensitive. We could leverage technology. And in fact, we're working now on a project to see if we can use artificial intelligence to provide earlier warning of climate hazards, including heat, as well as advise on what to do. It's not just enough to say it's going to be very hot and you better stay at home, but really to tell people, depending on their context, what they could do, where they could seek help, where there are cooling centers, where they can go, and also how to take care of their animals, because in villages, people are not worried that much about their health as they are about their animals' health. And similarly, schools now, we really need to build in climate sensitive curriculum. Our mental health program needs strengthening. It's already quite weak. And then on top of that, we know that mental health impacts are going to increase. In fact, there is a lot of projections that with increasing heat, people who already have a mental health illness and who are on psychotropic drugs, they actually tolerate heat much more poorly, but also that the risk of suicide might increase. And I did mention that we need more time use studies to make very clear the fact that women are spending more time in things that are really non-productive. So I want to, the last part, maybe just talk about coming back to universal health coverage again, and talk about a few ideas here. One is, of course, on the agenda setting and accountability. I mentioned Thailand as an example that, I have been really impressed with, of all the countries that I've seen, where this is a picture of their National Health Commission. So they have basically a people's health commission at the national level, state level, district level, down to the village level. So we're saying, okay, start with the panchayat and all the way to the national level. People have a voice and they can articulate what their priorities are. And they play a strong role in agenda setting, in the policy formulation, in policy adoption, implementation, all the way, through monitoring and evaluation and feedback to the government. We need to make that empowered. And we have a few such things like the Jan Arogya Samitis, which are supposed to function at the local level, at the level of the Health and Wellness Center. And it's sporadic. It works in some places, I think, where there are some committed people, but really the Gram Panchayat Sarpanch has to chair it and, take the lead. It has to have enough women and vulnerable sections of the population represented. And so that can be activated, and then that could be geared up and come up to the district, state, and then national levels. Again, we need, I think, localization in terms of comprehensive primary healthcare services. Every district really needs to know what are their 10 most common causes of death and 10 most common illnesses so that they can address them. And of course, these will vary by where you are located and the context around you is going to. And then integration, as I mentioned, that the community health officer today has 12 packages that she has to deliver. So package by package, she will deliver, and she also has to keep records like that. So recently came across a woman who had TB, but she was also pregnant and very anemic. But the TB staff basically looking after her TB, so nobody had said, you should also go and have your antenatal checkup and make sure that your anemia is corrected and so on. So this is what happens when you have a siloed approach. And of course, we still have a few vertical programs, but I think we have to focus on the individual, on the family. So if somebody is going in to the household to ask about something, it shouldn't just be that I'll go ask you about that one thing and come away, but really that health worker really should have the response, or that team should have responsibility for the comprehensive health. And now that we have these health and wellness centers, they deal with 5,000 population. So it is doable that that team, along with support from the medical officers at the primary health center, are keeping that population healthy, which means a lot of prevention, a lot of health promotion. And of course, then the referral systems also have to work well. Telemedicine and so on can be used much more and was used during COVID. So there is an opportunity there to get specialist care right down, to the village level. But we need to make those things happen. And then we have to expand our concept of health to not just health care, but to include the determinants like nutrition. So nutrition works, of course, through a different vertical program that comes through the Ministry of Women and Child and the Anganwadi centers. Water hygiene, air pollution, we talked about, and more we'll have to think about services for the elderly and disabled, and make sure that with climate change coming in, that every area is prepared for the kind of disasters they may face. So if you're coastal, you have to be prepared for floods. If you're in a hot, dry place, you have to be prepared for heat waves and so on. Human resources for health, this basically figure on the left is showing by state the density of qualified doctors, nurses, and midwives per 10,000 population. On the extreme right, you have Kerala, which has the highest density of nurses and doctors. And then Gujarat, Maharashtra, Uttarakhand on the extreme right. And on the extreme left, you have Bihar. And then Himachal, MP, Orissa, Jharkhand, Rajasthan, Nagaland. So there's so much variability in the availability of HR. And so in places which have enough human resources, we need to focus more on quality and redistribution. Whereas in those states which really don't have enough, I think the goal really has to be to increase the number of, and there are many, there are calculations as to how many human resources we need. It's also a good, because not just doctors and nurses, but you also need lab technicians, physiotherapists, radiographers, and so on. And so it's a big employment opportunity as well as serving the needs of the population. But right now we're at very low levels compared to what the standards should be. Again, we need role clarity for all members in the team, a shared understanding of population health as a whole, not just, this is my job and this is the register that I need to fill. And using platforms, digital platforms like Project Echo that, I've seen very nicely being used by NIMHANS, for example, to do mental health training. We can use that to build capacity and do regular mentorship. It's not just so much do one training, but really what these new cadre of people need. They're all quite enthusiastic young women, but they need ongoing mentorship and building of their skills. And then, of course, the data systems. Here's a typical picture of an Asha sitting with her records. I mean, she spends hours and hours trying to fill all these different registers that she has. And each of these frontline workers, whether they're Anganwadi workers, Ashas, or ANMs, do this. And now they also have to do digital. So they still do the paper and the digital. So really what we have to work towards is trying to reduce the burden on these women so they can spend more time with the people that they're supposed to be looking after in terms of health, reduce the burden of data, more sharing of data between departments, and hopefully the Ayushman Bharat Digital Health Mission should help. And then, of course, financing. I think there's no doubt everybody will agree that we need more financing, but we also need to do it as a more equity-focused kind of approach and performance-based allocations, particularly when we're talking about the private sector. Now, the PMJY, the health insurance program, works well in places where there is enough hospitals and health centers for people to go to. They can go to private or to public. They have a choice and they get reimbursed. But in places where there is no health facility, it doesn't work. So that's where the government really needs to step in. And again, we have to really regulate the private sector. The Clinical Establishment Act has really not been implemented by most states. And, there has to be some kind of outcome-based reimbursement of the private sector. And in certain things, the government has to take responsibility. Some states, I think only one, Rajasthan, has had a right to health law, but that's a good beginning and an example for others to follow. So finally, just want to say pandemic preparedness. I was involved in this report that we prepared for the Niti Aayog. It was chaired by Dr. Renu Swaroop. And essentially, we've recommended in 4 pillars various changes that need to be done or programs that need to be initiated, including a Public Health Emergency Management Act, because we're still using the Disaster Act of 1897 or something. So we need a updated Public Health Emergency Act, and then we need much more investments in research, innovation, and particularly community engagement and risk communication in this era of misinformation and disinformation that we live in. I think that's going to be a growing challenge for public health people. And we have to think about how we're going to make sure that people get the right information and they're not misled by, people trying to create confusion. So as I end finally, I think I have talked about the challenges that face us today, apart from a very large population and a large burden of non-communicable diseases. And we're not right now aging, but we will in the next decade or two gradually increase the number of elderly with lots of inequities, financing being not having kept pace, and climate change posing an additional burden. The solution is really, the only solution is to provide, good quality health services, particularly focusing on primary health care, comprehensive primary health care through the Ayushman Bharat and building on the infrastructure and other things that have already been established, but really focusing much more on how do you provide quality and comprehensive services with not just curative, but prevention, health promotion, and also rehabilitation, palliation, all of that, end-of-life care. There are many things, pain relief, that currently are really absent from our services. And then, of course, the how we're going to regulate the private sector, et cetera, because private sector is here to stay and they are going to keep providing health services, but we really need to find that balance. And then, of course, pandemic resilience is important because I think we don't want, none of us wants to think about COVID or anything like that happening again. But there is a very good chance that there will be a zoonotic infection, maybe not become a pandemic, but certainly within India, we've seen outbreaks all over the country of different viral infections, usually arising from an animal. And sometimes we know what it is, and sometimes we don't even know what it is, and a lot of people die. So I think building that capacity, and we've started doing that, needs to be done especially at the most distal levels of the health system. Thank you very much for this opportunity.
Thank you very much, Soumya. That was a masterly exposition of health policy in India over the years and what the challenges are today. Sanjay wanted me to also have participation from the audience, but we are running a bit late, I think. So if you don't mind, I would like to invite one or two questions if you have any, because, really Soumya has kind of given you the whole canvas and you might like to ask one or two questions, but only 2 or 3 max. Yes, sir. Yes, sir.
Malnutrition percentage in the country. How much GDP it reduces, by the way? If the country is malnutrition, what is the percentage and how much GDP comes down?
How much will GDP come down?
Due to malnutrition. And definition of health according to WHO Constitution.
Definition of health, that you can look up in the Google also. Sir. That's everywhere. Anyone, they've defined it. It's yes, sir.
This was S.S. Bhakdi from Institute of United Nations and UNESCO Studies.
Thank you. Yeah.
Yeah, thank you, Madam Soumya. Recently, we have achieved so much in our healthcare, and the way you pointed out your average age and other things, we have done a lot. This is achieved because of our population control to some extent, education and healthcare. And recently, we find that some politicians are trying to sabotage this healthcare and our achievement by saying, in political purpose, in South, there will be a delimitation and political delimitation will be less from South compared to the North. They want this, they should have more children so that they can have better presentation and get better revenue depending upon their population. One of the ministers, chief minister said we should have 16 children, then 2 children. So they have achieved in healthcare. So don't you think the whole this policy will be sabotaged?
I don't think so, right?
No, I don't think so.
I don't think so.
Some statements, I don't think we can take them as.
Yeah, so just one question from you.
I'm Pradipta Ghosh from the Energy and Resources Institute. You mentioned in your last slide about regulation of the private sector. You see, there are two well-known models of private participation in providing clinical health care. One is the health management agencies, and the other is the insurance-based approach. Now, in India, for the Ayushman Bharat clinical side, we seem to have adopted the latter. And this gives rise to a lot of perverse incentives to the private sector because of the difficulty and of actually monitoring what they're doing. Do you see a possibility by which we can transit from the insurance model to the health maintenance organization model?
Well, I'm not sure about that. So I think I don't want to comment on that in particular. But just to say that, as you rightly pointed out, the health insurance model, if it is not properly run, could actually lead to perverse incentives. That's one problem. And you get unnecessary procedures and unnecessary surgeries being done. Like in the case of cesarean section is a good example of how cesarean section rates just shoot up for no medical reason. But the other one also is that people who don't live in the vicinity of health facilities, then still don't get access. So then you're just, because the private sector is not going to go and build hospitals in remote places. So you're again leaving out those large section of the population. And so I think services can be obtained from them, but it has to be, and again, it has to be outcome oriented, not just for the process alone. But I think this requires a much bigger debate and discussion.
Ask a question.
Okay, so I have to give the last to the woman.
The woman.
Sure,
I
to
like
a
that.
woman, and you are quite the
Yeah.
woman, my
Hi.
friend and colleague.
Thank you very much for this
Meenakshi.
masterly, I mean, it's really, so comprehensive a canvas that you covered. I have two comments just. One is that I found even on the day when I came back to the health ministry after presenting the national population policy before the cabinet, the then Secretary Health met me on the staircase and said, "Bravo, I just hope that we in the health department read it." So what I'm saying is, even within the Ministry of Health, there is no integration between health care, health coverage, and the a population policy. So when we went to China, they said we have a ministry for population, precisely for this reason. Although we were invited by their National Family Family Planning Commission, but that Family Planning Commission worked under the Ministry of Population. So that's just a thought that I had. Second, en route to introducing treatment for HIV/AIDS on the 1st of April 2004, what I encountered was not only the abysmal availability of safe blood, but the fact that the health status of the candidate who's seeking to know whether he has HIV or not is never revealed to him and was never revealed to him. So prior to introducing treatment, the first thing I had to do was to amend the Drugs and Cosmetics Act, as you know, was 1840. And we had to amend that clause, which now mandated revelation of HIV status. My comment, the other thing is, probably for diabetes, we are at that stage. If you're going to have 250 million people in diabetic and pre-diabetic stages, then if we mandate the revelation of diabetic status, maybe that's something that can be thought of, just a thought. Thank you.
So thank you very much.
Yeah.
So I would like to now, before inviting Sumitra, for giving the vote of thanks. I'd just like to make a few comments. I mean, Soumya's talk has been so comprehensive that she has not left any gap for me to say, Soumya, you forgot this aspect. It's an excellent, really a masterly discussion. But I would like to leave behind a couple of thoughts for you to think of. That, and I think there's so many bureaucrats that I could have befriended when I was working my 18 years in Delhi. Why did I really grow to like Anita so much? And I think the one thing that we shared, Anita and those other colleagues who worked in the education sector, is that both of us really believed passionately that there can be no economic development or growth without centering education and health as the key elements and the key pillars of development. And I also don't think there can be any social development in our country unless and until, once again, health and education get center staged. So these are non-negotiable, but the tragedy of our development process in 75 years has been to neglect precisely these two pillars of development. That's the tragedy. And for 75 years, we've seen how health has never been given the priority that it deserved, nor education. And all my career went in running after the finance department to make some money available. So I would like to leave behind the 4 challenges. Soumya has really listed them out, but do think about it. That one, I would really say is that the basic challenge for India's health system is what is the relationship between state and the markets? I don't think we have really got that right. Should the state abdicate health, leave it to the private individual to make his own arrangement, or does state intervention have a role? Increasingly, privatization is being seen as state trying to get back. UP and Madhya Pradesh have recently are selling out district hospitals to private entrepreneurs. Is that a good development? So far, about almost 30 district hospitals are being handed over to health corporates. Is that a good development or not? Does having insurance policies, is it enough for individuals to then pay for health and go to the private sector while state really takes a step behind? So what is really the role of the state and how much should we intervene? And that, I think, then comes down to the situation where, do we have any values as a society? Whether it's Canada or UK or Thailand for that matter, equality and the firm belief that none should suffer for want of ability to pay were very passionately felt by every citizen in those countries, Canada, or many of these countries, Turkey. But then in our country, we don't really care. There's the differential care between the rich and the poor, between, what occupation you cover. I've seen in HIV/AIDS how a sex worker would never be seen by the doctor. She would go every day for treatment, but she would not be treated properly only because of her occupation, and so on and so forth. So we are a fractured society where we don't have that concept of equality, but values ultimately drive systems and ideas. And the third was the importance of the type of architecture. Why doesn't change take place in our country? The kind of primary healthcare we have today has evolved since 1947, but more or less static from 1972. And when Soumya mentioned this, that she's been going around primary healthcare centers, and she finds that the doctors their training is not suitable for the work they have to do in primary healthcare centers. Now, this was precisely the same wording too. Same observation was made by Dr. Mudaliar in 1959 in the expert committee. 1959, so many years have gone by. We know that the doctors in PHCs are not trained adequately to work in the PHCs, that our medical education is all screwed up. Why doesn't change take place? Is that something that has agonized me when I was in service, continues to agonize me now? How do we go a step forward? We are like stuck. And finally, how inclusive can we make the health system? There have been sporadic attempts. But overall, everything comes from the central government down to the individual. It's still very highly centralized. In fact, the trend is more towards centralization of policy and less towards having a inclusive, democratic, discussive, participatory kind of a system for precisely the kind of issues that Soumya raised: localized epidemiology, localized responses, localized solutions. That is not happening. So I really don't know how the design of health policy and health architecture can change, but these are some things I think we can think about. And I don't know how people in a democracy, we are supposed to bring pressure on the political systems to bring that change. I don't know how it works, because health is not an electoral priority at all, notwithstanding Mr. Kejriwal's mohalla clinics. So we have to, I suppose, rework our public discourse and our own understanding of politics works, because health is, not many of us realize, but is the most political topic of all the sectors. Most political is health. And that's where it is. So thank you very much. And I would now request Sumitra to please come and give the vote of thanks. She's from Mobile Creches, which is a very fascinating NGO. I think, I heard a lot of good things about it, but I've never really had an opportunity to see their work. Mobile Creches.
I have WhatsApped my vote of thanks to myself to read it out, because this is the 7th year that Sanjay has put me in as the last word, where I have to be fully attentive for 2 hours to make sure that I'm making sense, impromptu and extempo at the end of a glorious evening. Thank you, Deepa, for setting off, in sharing what we every year come together to celebrate the spirit of Anita here. A woman of steel, a fiery woman, a woman who gets things done, someone who stands up to power, especially someone who stands up to injustice. And that's the woman we celebrate year after year over here. So thank you very much for bringing her to life. Thank you, Dr. Swaminathan. It's an honor. It's a real deeply felt gratitude to have you as our keynote speaker, because of many reasons, and both Sanjay and you have already referenced to the reasons that your legacy of work resonates with what Anita has left us early with, an unfinished business. And you and many others like you continue on some of those values and those belief systems. So from the history of public health policy in India to you demonstrated how the impetus given by a few individuals within this ironclad bureaucracy that you mentioned, ma'am, and small teams and groups can really make change happen. And that is the hope that we live with, that change can happen, and the way forward that you have shown. Of course, the clarion call that all of us are taking away from Dr. Swaminathan's address today, climate change, mental health, TB deaths, a daily 1,000 TB deaths a day, a shameful statistic to be living with in this country. There are so many things that you alerted us to. But also a big clarion call to just, and what we already know, that how the public financing for basic public goods like health and education and other things going down year after year. You also spoke about the unfinished agendas, especially the increasing disease burden on the non-communicable sites and the aging population that is staring at us. So the whole demographic dividend narrative is going to change very quickly if we haven't got our policies and our systems at the right place. But in that, and you mentioned about the intersectionality on women and particularly children for that. But the other thing also is that the whole access, equitable access and access to quality. These two things that kept coming up throughout your conversation today. I think one, for me, a takeaway is connecting with Anita also that, whether it was her adult literacy program that led to the ARAC movement or the right to education movement and its intersection on life outcomes, I think visionary public policy thinkers have that power to lead one good policy, and that has an intersectional, rippling, exponential impact on many indicators, development indicators in the country. So thank you for reminding us that. And finally, I want to also reference to what Sujatha ma'am you said, and Soumya you refers to that ultimately who will change all this, and what Anita believed in, go to the people, listen to the people, talk to the people where it matters the most. So the people's voice and experience and how we can constantly remind ourselves to remain rooted in the lived ground experiences of some of the most poorest, marginalized, discriminated populations of our country. And I think therein the connection between Anita's family members, mobile crashes, rainbow homes, and Center for Equity Studies comes, that it's the profound legacy of our founders and many people after that who've constantly reminded us and kept us on track. Do not forget the people that we work for. Do not forget the people that we serve. Do not forget the power that you have as a medium to amplify people's voices. And that's how this evening comes together for all of us. Thank you, Sanjay, Rohan, and Divya, for sharing Anita with us every year. Thank you, the entire Kaul and Kriplani family, for having us here year after year and sharing a good evening with all of us. To Rainbow Homes, I can see Anuradha there and Vinoy somewhere, Center for Equity Studies, Harsh Ji in absentia, and my colleagues at Mobile Crashes for putting this together for all of us. Have a very good evening. But before we leave, we do have a small gratitude of our love to share with both Dr. Soumya and Sujatha ma'am. So may I request Vinoy and Rohit to please come as the Mobile Crushers and the Rainbow Homes people, and Anuradha, if you would like to join also, please. I can't be standing here alone. I make sure that I get my people. Please.
You're the only one who looks like Anita here. So, maybe Anita something. Come on. Thanks.
Thank you very much. Thank you so much. Thank you, Sumitra.